Hi everyone, welcome to researchmd.com. We got another great topic today. We're going to teach you everything about adrenal crisis, a very, very dangerous situation when you have to take care of a patient with adrenal crisis, okay? So we're going to teach you everything about how to diagnose it, how do you treat it, and what are the signs and symptoms to look for. Before we go into our topic, again, my name is Dr. Pramil Cheriyath. I'm a physician practicing in the United States, also program director, internal medicine residency and the transitional residency. I'm also an associate professor of medicine at two large medical schools in the United States and teach medical students also. So let's get into our topic, my friend. Again, our topic is adrenal crisis, okay? So everything before we jump into the topic, we just kind of know the definition, right? So let's look at our definition. That's the first step. Acute deterioration in health associated with the absolute hypotension. Remember that. Hypotension, systolic blood pressure usually less than 100, or it could be, you have to look at their baseline blood pressure. If it is less than 20 from their baseline, that also meets the criteria. Okay, so two numbers you have to know: the systolic blood pressure less than 100, or from the baseline 20 millimeter blood pressure drop. Okay, and lower than usual with the features resolves. That is the other part. Once you treat with the IV glucocorticoids, the symptoms will go away. Okay, so the two components into this: one, systolic blood pressure less than 100 or 20 below from the baseline, and then the features will disappear after you give IV steroids, IV glucocorticoids. Okay, that is the definition. Now, let's look at a little bit of epidemiology, because if we can express in numbers, then we know how serious the situation. That's why it's very important to know the numbers. I always tell everyone, make sure if we can express anything in numbers, you know the seriousness of the situation. Okay? So if you look at it right here, you got 6 to 8% of the people with adrenal insufficiency will go into adrenal crisis. And out of that, my friend, 6% usually die. Right? Very, very scary. Now, let's look at what are the risk and the precipitating factors in this kind of for adrenal crisis. Okay, number one is infection. What type of infection, you may ask? Bacterial infection in adults, and if it is children, it's usually viral. Okay, and then usually like stress. And the other one is GI illness. You can have like gastroenteritis. So what happened? They can have like nausea, vomiting, dehydration. And when you have like severe nausea and vomiting, you might not be able to take your usual steroid dose also, right? That can precipitate that. Perioperative period, surgery, be very careful. That's why we talk about before you go into surgery, make sure you adequately treat the patient with steroids if they have adrenal insufficiency. Okay? The next one is we talk about psychological stress, sudden discontinuation of glucocorticoids. You've been taking steroids for like a long time, and all of a sudden, maybe you didn't have the money to buy, or you were busy, you forgot to take it. That could happen. And then bilateral adrenal hemorrhage, pituitary apoplexy, old age, autoimmune disease, even type 1 diabetes and asthma. If you have heart disease also, you're at risk. Undiagnosed coexisting thyrotoxicosis also puts you at risk. Immunotherapy, or if you're receiving chemotherapy, all of this, my friends, can put you into adrenal crisis, which, remember, 6% of the people will die. So it's very, very important to recognize the signs and the symptoms. Now, before we look at the signs and symptoms, we need to understand the pathophysiology, right? What exactly happened right here? So let's look at the pathophysiology. We got our cortisol over here. So the main thing, we have cortisol is going to be decreased, right? Because when you look at cortisol, what is the half-life of cortisol? It's only like 90 minutes. And you got pleiotropic effect. That means the effect can like a lot of organs. Remember that, okay? So let's look at the first one. First one, why do we usually give steroid? Decrease inflammation, right? That's why when you have a COPD patient, you just give a little bit of steroid so they're going to feel better. So decreased inflammation. So if you don't have steroids, your inflammatory markers will go up all of a sudden, right? You got three things you have to worry. Interferon alpha, IL-1, and IL-6 goes up, cytokine storm. What does people when you have a lot of inflammation? Your body start having fever, fatigue, those symptoms can happen, okay? And then it can affect, it's activate the cellular inflammation. It can affect the brain. You can have delirium, okay? These patients can present with the delirium and fatigue. Remember that. Now, next thing we have to look at when you look at the adrenal cortex, cortisol has a synergic action with the norepinephrine, okay? And that keep our blood pressure, like vessels, vasoconstricted, and our blood pressure in control. So when you don't have cortisol, that synergic action no longer is there, okay? On top of that, the norepinephrine also will be decreased. That both of that is going to lead to vasodilatation, right? So what happened? Our blood vessels get dilated. Boom, your blood pressure go down, you collapse, right? And then so you get capillary permeability, and vasodilatation leads to hypotension. Remember, that's the main thing in our definition, right? Systolic blood pressure less than 100 and 20 decrease from the baseline. Remember that. Now, the third organ we have to look at is the liver, right? What happens in the liver? We know steroids will increase gluconeogenesis. If there is no steroid in the situation, you can have decreased gluconeogenesis. The main thing, your blood sugar will be less. Remember that. Okay, there's going to be decreased amino acids, and there's also decreased fatty acid synthesis also. Two other main things we need to remember. Okay, now let's look at what happens also. You're going to have aldosterone also is going to be decreased in these people. So what does that lead to? What does it lead to? Because you can have hyponatremia and you can have hyperkalemia. Okay, remember that. Those are the major things kind of happening up here. This gives us a clear picture. Once you understand the pathophysiology, you know the disease, you will know how to treat it and how to recognize the symptoms, right? So let's go to the signs and symptoms, my friend. Now we're going to look at the clinical features right here. GI, that's the first part we're going to look at. Anorexia, you can have nausea, vomiting, pain, abdomen pain is more common, limp and the back. Severe fatigue, these people have severe fatigue, severe weakness, and then postural dizziness because boom, the blood pressure goes down, right? And then syncope, you can have confusion, right? And then on examination, you can have abdominal tenderness or guarding is very common, hyperpigmentation only in the primary adrenal insufficiency, pyrexia, we talked about increased because all the cytokines increase, right? You can have like pyrexia from there. Now let's look at the blood pressure again. Blood pressure is going to be systolic blood pressure less than 100 and decrease in 20 from the baseline also could be used, right? It's a very, very important component. Now we look at the labs. You draw the labs. What are the findings you will find? Let's look at CBC. You can have like neutropenia. You can have eosinophilia and lymphocytosis, and you can have mild normocytic anemia. So remember, 4 things can happen when you look at your CBC. What are this? Neutropenia, right? Eosinophilia, lymphocytosis, and then you can have mild normocytic anemia. Okay, remember that. Those are the CBC finding you will find. Next thing we have to look at electrolytes, right? We already said like what happens over here because of the aldosterone is decreased, right? You can have hyperkalemia, right? You can have hyponatremia and hyperkalemia. Hyponatremia, hyperkalemia. You're going to have also hypercalcemia. And then what's going to happen to our blood sugar? What did we say it over here? Decreased gluconeogenesis, decreased glucose. The main important thing also, these people will have hypoglycemia. Okay? Now, let's come to the diagnosis. Pretty much you need to know the clinical features, the patient, and then improvement with IV glucocorticoids. This is the main way to diagnose it. If you check the initial test, the cortisol level less than 5, that's also going to be there. But if you order a cortisol time, it takes time for the lab results to come back. This is what you have to use your brain, come up with the diagnosis and act on it. Remember, the half-life of cortisol is like 90 minutes. So this thing can, when there is a adrenal crisis, is going to be like, boom, really fast. So don't order your blood test and wait for the cortisol to come back. Patient will be saying goodbye already, okay? So don't ever get into that situation. Use your judgment, look at the clinical features, give IV steroids and look for improvement, my friends. Got it? Okay. Now, how do you treat it? Very important. Two things, that's all you have to know. Hydrocortisone and then give IV fluids. But let's go in like how much IV hydrocortisone you have. First you give IV 100 milligram, followed by IV 200 milligram every 24 hours. Let's say if the patient is getting better after 24 hours, you can convert it into oral hydrocortisone, which is you have to take whatever they were taking, you give like 2 to 3 times dose higher you have to give, okay? Now, IV fluids, you start with giving a bolus, 1,000 ml, okay? Normal saline first. You should also give with the 5% dextrose, especially if there's like hypoglycemia. Got it? Okay. Now, let's look at the treatment. The best way, mnemonic, is always going to help me to remember some of the things. So if you want to look at the treatment, there's like 5S treatment, okay? What is the first one? S, remember, look, salt. What do you give IV fluids? 0.09% normal saline, right? Next one is sugar. You give 5% dextrose, okay? And the next S is steroids. Of course, IV hydrocortisone, give 100 milligram first, followed by 200 milligram every 24 hours. If the patient gets better, you decrease you convert it into oral, okay? And then S is supportive care, and the other S is search for always the underlying cause. We talk about all these precipitating factors. Don't ever forget it. You have to go and treat it, okay? So let's summarize this thing like one more time. We know the definition is what? The blood pressure, usually less than 100 or less than 20 from the baseline, and improvement in the clinical features after giving IV steroids. When you look at the mortality, mainly the patients have adrenal insufficiency. 6% of these people will die, okay, when they go into adrenal crisis. Remember that, the most important key point. And then you have all this precipitating factors we talked over here. What are the precipitating factors? Infection, stress, GI illness, remember the surgery, sudden discontinuation of hydrocorticoids, glucocorticoids the patient is taking. And all of the symptoms we talk about, any of them can precipitate it. But important one is the infection. Remember, what type of infection? Bacterial infection, my friends, in the adults and children. Viral infection. Okay, that's the most important thing. If you don't remember, if you know the pathophysiology, you know how to treat it, you know how to diagnose it. So I'm going to go over just fast looking at our board one more time. Make sure you look at the board. That's the best thing about this whiteboard. You can just kind of look at it. You don't need that's why we don't do PowerPoint presentation. You need 1,000 slides to explain it, right? In this thing, I have a beautiful whiteboard and everything is there. By one look at it, I know what's going on. That's why we do a presentation like this, my friend, okay? Don't forget it. Now, so you got cortisol right here. The main thing is cortisol is going to be less. Remember, it's an inflammation. Cortisol decreases inflammation. If you don't have cortisol, there is increased inflammation kind of going up. You got interferon alpha, IL-1, IL-6, and all of this go up. You can have fever, fatigue. It goes to the brain, delirium and fatigue. And then remember the synergic effect with the norepinephrine, okay? That's kind of, they usually keep the blood pressure in control with the vasoconstriction. That's no longer there. Vasodilatation, capillary permeability. Main organ, look at the liver, decreased gluconeogenesis and the glucose will go down. Look at the muscle, decreased amino acid and the decreased fatty acid. And then look at aldosterone is going to be also decreased. So that will decrease the sodium, increased potassium. Okay, so this thing we need to know. We need to understand what are the clinical features. Severe fatigue and severe weakness, and then abdominal tenderness, and then remember the hypotension. I'm going to say it again, less than 100, and then 20 millimeter from the baseline. Also, they be considered. Okay, don't always look for, oh, the blood pressure is normal. No, look at the baseline. Did it drop like less than 20 with associated features? Okay, now let's look at our CBC. What are the CBC? Neutropenia, eosinophilia, lymphocytosis, and the last one, mild normocytic anemia. Then we look at the electrolyte. Three things we need to know. Because of the aldosterone, what happened? Sodium goes down, potassium goes up. Everybody knows that, right? You can also have hypercalcemia. And then what happened to our glucose? We know decreased gluconeogenesis, decreased glucose hypoglycemia. Okay? Remember, I'm going to say this again. Don't order lab tests to come for the diagnosis. Look at the clinical features and diagnose it, okay? Because if you order a lab, you can see cortisol will be less than 5. But by the time the results come back, most of the labs take forever to get the cortisol. Maybe 24 hours, your patient will be goodbye, right? So don't get into that situation. And then treatment, remember, hydrocortisone and IV fluid. 2 treatment, that's all you have to know. IV hydrocortisone 100 milligram, and then IV 200 milligram every 24 hours. Patient get better. Think about decreasing to oral corticosteroid, but you give 2 to 3 times of the dose patient is taking at home. Don't forget it, okay? IV fluids, you give 1,000 bolus first, right? And then followed by, you can give like a 5% dextrose, and then because these people can have hypoglycemia, that's very important. Always remember the 5S. What are our 5S? S for salt, which is 0.09% normal saline. Second S, sugar. And the third S is steroids. And number 4S is supportive care. Number 5S is search for the underlying causes. Okay? It's always very important to find that cause and treat it. Don't forget it. Thank you so much for watching this presentation. We'll be back with another presentation. If you could help us subscribe to the channel, we will really, really appreciate it. Thank you so much again. God bless. Steady heart.